A newborn boy with X-linked Agammaglobulinemia, or XLA, enters the world appearing perfectly healthy. He breathes, sleeps, and grows exactly like any other infant. Physicians have noted this silent period for decades. The infant appears fine, showing no outward symptoms of the severe immune deficiency hidden in his DNA. This chart shows the biological reason for that early health. During the third trimester, mothers actively transfer IgG antibodies across the placenta. This high peak at birth represents a borrowed defense that temporarily shields the infant. The baby is safe for now, but these inherited antibodies have a limited lifespan. A biological clock is ticking as the infant's borrowed protection begins to clear from his system. As the infant reaches 6 to 9 months, maternal protection steadily decays. A healthy child would begin producing their own antibodies now. In XLA, that production never begins. This creates an empty gap in the body's defenses, leaving the infant entirely vulnerable. Pathogens exploit this opening immediately. These spherical chains of Streptococcus pneumoniae are among the first to invade, causing recurrent ear infections and pneumonia. Other encapsulated bacteria, like these rod-shaped Haemophilus influenzae, also frequently attack the respiratory system during this period of vulnerability. The maternal shield is gone, and no replacement defense has formed. The respiratory system is completely unprotected exactly when these bacterial threats are most likely to strike. To find the source of this failure, we have to look past the ears and lungs and move deep into the bone marrow. This is the birthplace of B cells, or B lymphocytes. These specialized white blood cells are the factories responsible for manufacturing every class of antibody, including IgG, IgA, and IgM. To mature, a B cell needs a chemical signal from Bruton tyrosine kinase, or BTK. In XLA, a mutation halts this process. XLA follows an X-linked recessive pattern. Males have only one X chromosome, so a BTK mutation completely stops mature B cell development. A single genetic error shuts down the antibody factory. The body is left unable to manufacture a single defender before the first infection arrives. While the history of infections is significant, the physical examination reveals a specific anatomical detail. The physician examines the child's throat for secondary lymphoid tissue. In patients with XLA, the tonsils and peripheral lymph nodes are unusually small or completely absent. These tissues are structurally composed of B cells. Because the genetic mutation prevents those cells from ever developing, the tonsils and lymph nodes never grow to their normal size. The physical absence of these glands provides a visible indicator of the microscopic genetic void within the immune system. Physicians must confirm XLA by ruling out other primary immunodeficiencies, such as CVID or severe combined immunodeficiency. Blood analysis shows the severity of the defect. While a healthy patient has a normal B cell count, an XLA patient shows profoundly low immunoglobulin levels and a peripheral B cell count of less than 1%. Definitive confirmation is reached through direct sequencing of the BTK gene, identifying the exact mutation responsible for the maturation block. This molecular diagnosis allows the medical team to move beyond managing infections and begin a lifelong survival strategy. Management requires lifelong immunoglobulin replacement therapy. Purified antibodies are infused intravenously or subcutaneously to replace what the body cannot make. This therapy provides a constant supply of protective antibodies from healthy donors, functioning as a necessary substitute for the patient's missing B cells. Research is now moving toward curative options. Scientists are investigating CRISPR and gene therapy techniques that may one day fix the BTK mutation directly within the patient's own stem cells. While the mutation stops the body from developing its own defenses, medical intervention provides that missing protection externally. With continuous therapy, patients with XLA can